So now we have a keynote lecture by Dr. Peter McCluskey. He is a professor of clinical ophthalmology and eye health, director of Safe Sight Institute, faculty of medicine and health clinical ophthalmology, eye health site, Sydney Eye Hospital from Australia. He'll be talking to us on scleritis survival guide. Over to Dr. Peter McCluskey. It is nice to have him. We have done the collaborative study on scleritis with him.
Yes. Thanks very much, Padmalini. It's a pleasure to be here, and it's good to see everyone in the flesh after 3 years of Zoom meetings. And the study that Padmalini and I did were both part of has been a very useful study. So my talk this afternoon, I've been asked to give a scleritis survival guide, and it follows on nicely for those of you that were in the previous session on what we were discussing last time. And there are really 5 key messages that I want to give you about scleritis. We all know it's a rare disease, but it's an important disease because it's a significant threat to vision and it causes a lot of pain. We know that up to 50% have an associated systemic disease, which can be a threat to not only sight but to life. We know that the risk of having a systemic disease is more frequent as the scleritis gets worse. We know that at least 10% of scleritis is infective, as we were talking about in the previous session. And the 5th point is really the treatment and how we match our treatment to the disease. So the first important thing is Mr. Watson's classification, which is close to 50 years old now, has stood the test of time. It's like most good things, it's relatively simple, anatomical into anterior, posterior, or both anterior and posterior, and then the severity of the inflammation, the most severe being necrotizing or non-necrotizing, and non-necrotizing can be diffuse or nodular. The other important thing that Mr. Watson taught us all was that the diagnosis of scleritis is predicated around its clinical presentation. And he always used to say that if you weren't thinking of the diagnosis by the time you'd finished taking the history, you often wouldn't make the diagnosis, because that history of severe, dull, aching pain that's retrobulbar, radiates to the jaw, to the ear, to the scalp, gets worse at night, classically early in the morning, wakes the patient from sleep, and is relatively poorly responsive to analgesics, is the hallmark sign or symptom of scleritis. The physical signs of scleral edema, vascular dilatation, and vascular closure, as you can see on the slide here, they're the classic clinical signs that we look for when we're assessing the severity of scleritis in someone where we think that's the diagnosis. As I said, one of the key things is that there are 3 classic types of anterior scleritis: diffuse and nodular, which are the non-necrotizing forms, and are the commoner forms of scleritis, and then necrotizing scleritis, which has a significant threat to vision and the integrity of the eye. The most important thing is as you go from diffuse to necrotizing disease, not only is the inflammation getting more severe, but the risk of having an associated systemic disease is higher. There are a number of important systemic diseases that we need to think about. Rheumatoid arthritis remains the commonest. The most important disease for us as ophthalmologists to think about are these things called the ANCA-associated vasculitises. Rheumatoid arthritis is usually readily diagnosed and previously diagnosed in our patients with scleritis. There are a small group of patients with scleritis who do have rheumatoid disease. They have, a positive CCP titers, but they don't have deforming rheumatoid arthritis and a long history of rheumatoid, but that's the minority. Getting back to the ANCA-associated vasculitis, this is the group of patients that present to us, particularly granulomatosis with polyangiitis, what used to be called Wegener's granulomatosis. It commonly presents with orbital and ocular and scleral inflammation, and an important disease for us to recognize. B27-related disease, ankylosing spondylitis, inflammatory bowel disease, other seronegative arthritis, they can be associated with scleritis. Many forms of systemic vasculitis can be as well. It's important not to forget that disease, relapsing polychondritis, and there's a range of other diseases from gout through sarcoid and IgA nephropathy that we need to think about. It's important to realise that necrotizing scleritis is not only a threat to our sight, but also to patients' lives. And although this publication from Steve Foster is 40 years old, the premise of it remains the same, that if you don't treat patients with necrotizing scleritis to get their vasculitis under control, because so many of them have an associated systemic disease, many of those patients will die from their systemic disease if we don't treat the whole thing aggressively. And these patients, as I say, their initial presentation, particularly with ANCA-associated vasculitis, can be to the ophthalmologist. I mentioned earlier that 10% of scleritis at least is infective. In the last session, we spoke about post-pterygium infective scleritis, which is commonly either Pseudomonas or a fungus. But we need to think about systemic infections such as TB and syphilis and herpetic disease, particularly zoster. We also need to think about infection in patients with a history of trauma. We need to think about contiguous spread, particularly from herpes simplex and acanthamoeba keratitis, and also just occasionally really severe intraocular inflammation, typically either viral retinitis or toxoplasmosis, can end up giving you spread to the sclera and give you a scleritis and almost a panophthalmitis. So the last of the 5 points is really how do we treat scleritis? And this is really quite a neat algorithm that talks about how to treat non-necrotizing anterior scleritis versus posterior and necrotizing scleritis. And essentially we know that non-necrotizing scleritis will usually respond to an oral NZ or oral steroids, and only a small number of patients need additional immunosuppressive therapy with drugs like methotrexate or other DMARDs. Whereas those patients with posterior scleritis, because it's a serious threat to vision, and with necrotizing scleritis for the same reason, they typically need combination immunomodulatory therapy with oral prednisolone and additional immunosuppressive drugs, which we'll talk about in a moment. There is a place for subconjunctival steroids in a carefully selected group of patients, but in a region such as India, where TB and infection are common, we have to be very careful about using regional steroids. So, getting back to systemic therapy, the treatment's really proportional to the severity of the scleritis. As I mentioned, non-necrotizing anterior scleritis typically gets better with oral steroids. We need immunomodulatory therapy for necrotizing and posterior scleritis. We may need to add treatment to what they're already on for their rheumatoid arthritis or ANCA-associated vasculitis. But in conjunction with the rheumatologist and the immunologist, we can taper the treatment or tailor the treatment to control both the scleritis and the systemic disease. It's also important to realise that some of our patients with infectious scleritis will need oral steroids and occasionally a drug like methotrexate to help control the associated severe collateral damage from the inflammatory response. As I mentioned earlier, necrotizing scleritis is the nastiest form of scleritis, and once you're confident that it's not infectious, sometimes you actually need to use intravenous methylprednisolone, although most of the time high-dose oral steroids will be quite satisfactory. Additional immunosuppressive drugs like methotrexate and cyclophosphamide are very useful in this disease. And now that we have the availability of biologics, B-cell depleting agent biologics such as rituximab and TNF blockers can be useful in the right patients. I mentioned earlier that infectious scleritis is an important disease and we need to treat that with appropriate antimicrobial therapy. If it's tuberculous, with ATT, if it's bacterial, with obviously the correct systemic and topical antibiotics, and the right antifungal drugs if it's a fungus, and the fungi in particular can be really very, very difficult. Sometimes we use therapy such as this continuous subpalpable infusion with antibiotics or with antifungal drugs, and for patients, one-eyed patients, patients with really bad necrotizing infectious scleritis, this can actually salvage an eye that otherwise would not have survived. So just to recap, there are 5 key messages that I wanted to get across. A rare but important disease, a disease that's commonly associated with systemic disease. The risk of systemic disease increases as the severity of the scleritis increases. Never forget infection, and make sure that you treat the patient aggressively enough to control the disease. So thanks very much for your attention.
Thank you, Dr. Peter, for the excellent talk on scleritis. I would like to get your guideline. Post-COVID, we are seeing a lot of patients with Varicella zoster virus reactivation, and they do present with scleritis. What will be your guideline for the management of such cases?
Of sclerotic TB, yeah. So we don't see a lot of that, fortunately, in Australia. It's usually multibacillary disease, so they need anti-TB therapy. They will need often some anti-inflammatory therapy as well. I think prednisolone is the best drug to use there because it's relatively easy to stop it if you need to. It's uncommon for them to need ongoing immunomodulatory therapy in my experience, but I think I would really bow to the much greater experience that you guys have here in India with tuberculous scleritis.
Anyone has questions? Dr. McCluskey, what's your first choice of immunosuppressives in these patients? Which is the drug that you would like to start first?
Look, I think methotrexate is the best drug to start with. It's easy to use. It's very affordable. Everybody, in a sense, is comfortable using methotrexate. It's not inferior to any of the other drugs, and I think it's a really useful medication for immunomodulatory therapy.
I would agree. So even our first line therapy for immunosuppressants generally is methotrexate, since it's so well tolerated.
Yeah, and in scleritis, if you need another one, particularly in an older patient, we would tend to go to cyclophosphamide.